So I'm welcoming all of you, and I'm requesting Dr. Deepmala ma'am to start the proceedings. Welcome, ma'am. Please start the
Amit,
Thank you, Dr. Pankaj.
Amit, can you send
Now,
Dr. BB Wadwa's link again? He's having slight problem.
Okay,
Yes, sir. Yes, sir.
okay. Time to invite our dynamic president, Dr. Mukesh Verma.
सर भेज रहा हूँ 1 सेकंड बस.
I can't see. Hello. Am I visible and audible?
Yes,
Ma'am, you are visible.
Yes, you are visible, very much visible and
Yes,
audible.
ma'am.
Okay. So
Just
I
we are trying
welcome
to
Dr.
add
Mukesh.
Dr. BB Wadwa. Can we wait for 1 minute? I am trying to add Dr. BB Wadwa on the. Amit, can you send Dr. BB Wadwa's link?
Sir, already sent.
Send to me. I will send him.
Definitely, sir.
Can you see?
Just a minute.
I welcome Dr. Mukesh, our
जी, ma'am.
dynamic president. I request Dr. Mukesh, please आप भी 2 शब्द बोल के इसका प्रारंभ करिएगा.
जी मैम. First of all, I would like to welcome everyone on the panel list and the delegates. Dr. Amardeep, Dr. Amarpreet Riya, Dr. Arun, Dr. Sunil Gupta, Dr. Aditya Pradhan, Ma'am Deepmala, Dr. Piyush Ranjan, Dr. Prakash Talchandani, Dr. Preetham and Dr. Rakesh. Dr. BP Wadwa is just going to join. I have given the link. Meanwhile, Dr. Prakash, you can coordinate with Dr. Wadwa why is not able to join the webinar. And this is the, I'm thankful and welcome you all, and special gratitude that you all have spared your Sunday afternoon for this webinar. And IMA Dwarka has always been an active organization or active association in organizing academic programs, CMEs, conferences. But this year was unprecedented due to the corona epidemic. And for the first few months, we were just observing lockdown, and we had other important agendas and issues in our hand, apart from organizing the academics. We were having time, really challenging time, and we were helping the fraternity with in COVID time for their protection, other important items like the welfare of the fraternity, their safety, security, and the safety security of the fraternity member was of prime importance during the corona pandemic time. And we also, during this time, we utilized this opportunity to meet the administrative heads, DCP, ACP, police administration, and the government to so that the government announced relief packages, compensation, a COVID task force was also created during this time to look after the medical needs, the bed availability of ICU beds, plasma, and any financial help that the fraternity members needed. Gradually things are normalizing. I should not say that things are normalizing. In fact, things are not normalizing, but we are gradually adapting to the new normal. In fact, the cases are increasing, but now we have adapted ourselves. And this academic series today is also part of that adaptation. And we have started following the new normal. And so we try to start this academic series to tie the membership academically as well as socially. So today is the first of the series, and I welcome you all. And I pray to the God that all our fraternity members should be safe, healthy, And I also extend season's greeting. The festivals are coming. Season's greeting to all of you. Dr. B.B. Wadhwa, President DMA, is also here. Dr. B.B. Wadhwa, sir, welcome you, sir.
Thank you. Thank you very much.
With that, I will again hand over the charge to Dr. Deepmala. Thank you all. Thank you all the delegates.
Thank you, Dr. Mukesh. We are honored to have with us the Vice President DMA, Dr. Prakash Lalchandani. He's twice he has been the President of IMA Dwarka. He's a product of IMA Dwarka. I hope कि उनकी presence DMA में हम IMA Dwarka के लिए बहुत बहुत लाभकारी होगी और वो कुछ हमारे लिए कुछ सोचेंगे IMA Dwarka के लिए. Dr. Prakash Lalchandani.
Thank you, Dr. Deepmala. I take this opportunity to welcome Dr. Wadhwa, President, Delhi Medical Association, President IMA Dwarka, Dr. Mukesh Verma, Secretary, Dr. Preetam Pankaj, all the speakers, panelists, and delegates. Frankly speaking, I'm missing the camaraderie of the offline meeting. But as we say, survival of the fittest, and we have to adapt to the new normal. So this is the way we can go forward to begin with. And here it is the first CME, the IMIdcon, the digital form of our MIdcon, the flagship event in the IMA Dwarka itinerary. So ladies and gentlemen, we have started our programs with this first series. And very soon we will have the second program after this, and slowly and steadily we'll move to the offline program. And December, in very shortly, you will hear the news of the first offline program of IMA Dwarka. For that, initial preparations are already in the full swing. Why in the last 6 months have been they are the great revelation and great equalizer among all the members and the various class of the society. Corona has busted few myths also, and made us realize the value of friendships and time with us. Frankly speaking, last 6 months have been spent on, as Dr. Mukesh has already briefed, on the various efforts done by IMA Dwarka for the members' welfare, procurement of PPEs, procurement of masks, procurement of sanitizers, managing the beds in the hospitals, managing the plasma for the relatives and the family members of the members, and all these things in the line. These 6 months have ensured more bonding among us also, because when in the good times everyone is goody, and in the bad times you get to know who is with you, who is not with you. So this is, as I said, Corona has taught us too much. So चलिए इस बात को यहीं छोड़ते हैं और अपने प्रोग्राम की तरफ चलते हैं. And once again, I welcome Dr. Wadhwa. I can see him now. He is a great person, very affable personality, and leading the DMA from the front. And as you see, DMA, I have got the opportunity to work with him as a senior vice president. And lately, we saw DMA in action in Hindura Hospital, and we got the problem solved after the series of meetings with the Mayor, Health Minister of India, Dr. Harshvardhan, and by efforts of everyone, the problem was resolved amicably. I hope the long-lasting solution can also be found. Thank you very much for now, and let's proceed further. Handing over to Dr. Deepa.
Thank you, Dr. Prakash. It is privilege for IMA Dwarka to have DMA President Dr. B.B. Wadhwa sir with us as a chief guest. Sir, I hope you must be remembering how the IMA Dwarka used to organize the programs. But sir, time is like that, and we all have to evolve. So in Corona Kal, I think virtual meetings are the best thing to do. So I'll request Vadwa sir for a few pearls of wisdom, sir. Dr. Vadwa, please.
Thank you, Dr. Deepmala. First of all, I would like to thank IMA Dwarka for inviting me in this webinar. It's a new normal things what we are seeing nowadays. I have been addicted to coming to Dwarka from last 5-6 years. Dr. Prakash Lal Chandan is kind enough to call me in every conference of IMA Dwarka. I am thankful to IMA Dwarka for that. I am thankful that Dwarka has given me the most dynamic Vice President of Delhi Medical Association, who has been working with me shoulder to shoulder in every time. Whenever I ask him, he is there. Though I know it is quite far away from Delhi Medical Association, but he never lets me down. He is always there with me. And we have been working together. In this Corona time, it was very hard on us as we were not able to do any type of CME or conferences like that. But we innovated a new way. We innovated Doctors' Day, and we went to honor the Corona warriors on Doctors' Day, and we went to all over Delhi, and Dr. Prakash was always with me in that. After that, as Dr. Prakash has mentioned, but before that, we organized a very good Foundation Day program in Delhi Medical Association, and that was to inaugurated and virtually by Dr. Harshvardhan, and you are all present in virtually or physically there. After that, we organized a memorable Women's Day, August Utsav, and Dr. Deepmala was instrumental in organizing such a good program. I compliment Dr. Deepmala on that. And we will remember always that that was a very good program. Technically, in India, we are not so sound, but even then, we managed to do that, and it was appreciated all over. And recently, there was a strike of North DMC doctors, and the children, resident doctors, were on strike from 13 days, but no one was listening to them. Then Delhi Medical Association, and particularly I will mention Dr. Prakash Lal Chandani. He always asked me, why DMA is not doing anything? Why DMA is not doing? I asked him, यार वो कॉन्टेक्ट ही कर रहे हैं हमारे से, बच्चे जाके जंतर मंतर पे धरना करते हैं और हमें बताते भी नहीं है कि हम जंतर मंतर पे धरना कर रहे हैं. तो मैंने एक डॉक्टर से नंबर लिया. मैंने कहा यार आरडीए का प्रेसिडेंट कौन है, जरा मेरा से नंबर तो दो मुझे. तब मुझे I got the number of Dr. Abhimanyu. Then I asked him, yaar, why you are not calling us? We will be there to help you. Then I went to Hindurao with Dr. Gambhir, Dr. Prakash, Dr. Alok Bhandari, and a marathon meeting was there in MS office, Dr. Anu Kapoor. After that meeting, we had a series of meetings with mayor, with the commissioner, with the other this resident doctor and the senior doctors also. And you have seen the result that we were able to release the salary of all the doctors and the seniors. When the seniors came with us, that was a very good step, and we showed that unity we have shown in this strike. तो जब डॉक्टर्स सब इकट्ठे हो जाते हैं तो एक अलग यूनिटी लगती है. उससे जो है मेयर साहब को भी समझ में आ गया कि नाउ वी हैव टू accept the demands, and that after that we went to the commissioner also to certify that the mayor is saying where mayor is a political person. So हमने जो है उस चीज के लिए पक्का करने के लिए कि हाँ इस चीज को होना है, तो कमिश्नर के पास हम गए थे, and commissioner did in the written he gave us that the salary is to be released and a permanent solution should be found. In that permanent solution, we will be discussing with the mayor as well as MCDA doctors, RDA doctors, Delhi government also. because the mayor was saying that Delhi government is not releasing the funds to the doctors, and we are not able to do. But what we said, that salary is a planned expenditure. Why you are spending the salary amount to the other heads? So you should take care of this. So he assured us that we will not do this now, and that salary of the doctors will be released on time. So DMA is working in limitations. Of course, Corona has taught us many things, and we are working for the society. There are many issues we are facing. I think I should narrate that also to you, that in the future you may also get the notices of biomedical waste, solid waste, and something, or fire issues of nursing homes. So many issues are there. So I want the help of active Dwarka members branch in solving these issues, and I'm very happy that Dr. Prakash is always with me in every issue, and he is very active in suggesting me the ways how can we proceed. And I am thankful to the IMA Dwarka that they have invited me on this webinar, and in the near future, the way Dwarka branch is working, I am seeing a DMA president from that branch also. So with this, I wish them good luck. And for this webinar, I think that you will be learning much more by the speakers. It's a very good initiative by the IMA Dwarka branch. Thank you very much.
Thank you, sir, for such a motivational words. So definitely, sir, DMA president हमारे यहाँ से जरूर होंगे. Thank you so much for taking out your precious time. Now, time to start with the scientific sessions. We are very much thankful to Venkateshwar Hospital for organizing this first ECME for us. The first topic is surgical aspects of renal transplant, and the speaker is Dr. Arun Anthony. The chairperson for this sessions are Dr. Subhash Seth. He's presently in SAG in Delhi government and senior executive of IMA Dwarka. He's a guiding force for all of us. And the second chairperson is Dr. Aditya Pradhan. He's a senior neurosurgeon in BLK Hospital with the special interest in robotics surgeries. Always he has supported academic activities of IMA Dwarka. So welcome Dr. Seth and Dr. Aditya.
Thank you.
Thank you, Dr. Deepmala. It's a nice way to make a beginning to improve the academic wisdom in new normal. The privilege to present Dr. Arun Anthony to this august audience. Dr. Arun presently is consultant urologist at Venkateshwar Hospital, Sector 18, Dwarka, since July 2018. He did his MBBS and MS from Government Medical College, Trivandrum, and then MCH in urology from Rajiv Gandhi University of Health Sciences, Bangalore. He's a urologist, andrologist, and renal transplant surgeon with an overall experience of over 11 years. Deals with diseases of kidney, ureter, bladder, prostate, and urethra, including cancers of these areas. Is well versed in all endourology procedures like PCNL, TURP, TURBDT on one side, and more advanced procedures like nephrectomy, BMG, urethroplasty, etc., to name some. He also practices andrology and deals with pressing issues like erectile dysfunction, male infertility, and other male sexual problems. As a transplant surgeon, he has worked at various centers and has an experience of over 100 renal transplants, which includes doing and assisting transplants. Today, he'll be discussing surgical aspects of renal transplant. Presenting you Dr. Arun Anthony. Dr. Arun, please.
Good evening, sir. Can you hear me, sir?
Yes, you're audible.
Okay. Good evening to all. Good evening to all my seniors, my friends, my colleagues. I'm humbled to be given the opportunity by IMA Dwarka to give this presentation in front of such an august audience. So I will just be sharing my screen. Is my screen visible?
Yes, sir, you're visible. You can talk.
The screen is
Okay.
not visible so far.
Seen.
Can you see the picture of the Venkateshwar Hospital?
No, your slides are not up
No,
yet.
your slide is not uploaded.
Pardon?
Your
Yes.
slide not visible.
Not visible.
Yeah, you are
Okay.
visible, but your slide is not visible.
Do the screen share first.
Yes.
Have you got screen share on?
Now,
Yeah,
yeah.
now it's
Yes,
visible.
yes,
Now it's visible.
Okay, okay.
Good, great.
Yeah. Yeah. So good evening to all. I'm Dr. Arun Anthony. I'm working as a consultant in the Department of Urology and Renal Transplant at Venkateshwar Hospital, Dwarka. So today my topic is discussing about surgical aspects of renal transplantation. But at the same time, I will be discussing briefly about all the aspects so that we get a holistic approach and we understand the whole idea of transplant in a gist and in brief. So the first thing is, who are the patients who need to be selected for kidney transplantation? All the patients with ESRD. ESRD is end-stage renal disease. All these patients are candidate for kidney transplant unless and until there are some other issues with them, like a systemic malignancy. Now, if we talk about malignancy, if the recipient or the person who has the ESRD is having some cancer, in that case, we would like not to do a transplant in the immediate setting. Now, this also depends on what is the malignancy that he is having. There is a lot of background noise. Hello.
Can you request the administrator to mute the haters, please?
Yeah. So if we are talking about solid malignancies like breast, colorectal cancer, or diffuse bladder cancers, then in that case, the waiting time would be 5 years for the treatment. But if we are talking about some other malignancies like an isolated nodule in a prostatic cancer, or if it's a very small bladder tumor which is stratified as a low risk, then the transplant can be done even after 2 years. And there are certain malignancies for which immediately after treatment of that cancer, the transplantation can be done. One to name an example would be renal cell carcinoma. So, and if the patient has a chronic infection, he is not a candidate for ESR for renal transplantation. Severe cardiovascular diseases are also considered as not an ideal case for transplant. But I would like to emphasize that we at Venkateshwar Hospital have done a renal transplant in a patient with a triple vessel disease. He had an ejection fraction of 30%. Of course, no credits to the surgical team for this. It's all kudos to the anesthesia team who did a fabulous job there. And we did this transplant, we did this recipient under spinal anesthesia. And if the patient has a neuropsychiatric disorder or if there are extremes of age, then again, doing a transplant in extremes of age is a relative contraindication. Let me just go back to what exactly is ESRD. ESRD is a state where the patient has a GFR which is less than 15 ml per 1.73 square meter of the body surface area, which is present for more than 3 months. Or even if the patient is regularly on dialysis, there is a continuous need for dialysis, but the GFR is more than 15, then also that is technically ESRD, and all these patients are candidate for renal transplantation. Now, previously there was a concept that HIV is a contraindication for renal transplant. Now, the whole ideology or the concept behind that was HIV itself is an immunocompromised state, and after renal transplant, you are going to dose up on the immunosuppressants. Now the concepts are changing. Now HIV is no longer a contraindication if the CD4 count is more than 200 per microliter for 6 months. HIV RNA is undetectable, and the patient is stable on antiretroviral therapy for 3 months. Again, we at Venkateshwar Hospital have done one case of HIV positive recipient. The patient was not Indian; he was an African patient, successfully transplanted back in his home country, doing well. He does follow up sometimes on WhatsApp. He is doing perfectly all right. So that was a case we did. This was the first time we did an HIV positive case. Now, some things that patients want to ask is, what is the patient survival after kidney transplant versus hemodialysis? It's a very, very common concern from the patient side. This and cost. They always ask about these two things. So regarding the annual mortality rate, now if a patient is under dialysis, the annual mortality rate ranges from 21 to 25%. This goes down drastically to less than 8% when we are talking about a cadaveric transplant. And it goes down to less than 4% with living related transplant patients. And if we talk about the projected years of life for a patient of 20 to 39-year-old, then you can see that if the patient is on dialysis and non-diabetic, the lifespan on average is 20 years, whereas a transplant patient has an average lifespan of 31 years. Now, just I want you to focus on the data when the patient is diabetic. Look at the drastic change. Now, if the patient is diabetic and on dialysis, the average survival is 8 years, whereas on transplant, it's 25 years. So, two things. If the patient is young and if the patient is diabetic, transplant takes a much more upper hand over dialysis than in normal circumstances. Even otherwise, transplant has an upper hand. But then if the patient is diabetic, the patient is young, that upper hand becomes even more upper. Now, coming on to the kidney donor. Now, who can be a donor? Now, this can be a living related donor, living unrelated donor, as well as a cadaveric, that is a brain dead donor. What is the criteria for a living donor selection? So it should be related. He or she should be highly motivated. Preferably should be ABO compatible. Of course, we are doing ABO incompatible as well, but if it's possible, always opt for ABO compatible. Negative cross-match with the recipient, and the donor should be in excellent medical condition. And of course, he should have normal renal function. That goes without saying. Now, though the talk is specifically about live-related donors, but I've also added a slide about criteria for cadaver donor just for completion's sake. So here the criteria is that the donor should have irreversible brain damage, normal renal function appropriate for age. There should be no evidence of pre-existing renal disease or transmissible diseases. ABO blood group, of course, compatible and negative cross match, as well as the best HLA match possible, which is in cadaveric cases, we select the donor recipients from a pool of patients. So of course, it's easier to match. So best HLA match possible, particularly at the DR and V local. How do you evaluate a potential kidney donor? A proper and thorough history and physical examination, a complete blood count and biochemistry, urine analysis, 24-hour protein, normal ultrasound of the abdomen and chest X-ray, a DTPA scan, which helps us to understand the function of the kidney, the split renal function, and the CT renal angiography, which helps us to assess how many vessels are there. Is the kidney supplied by a single renal artery? Are there multiple renal arteries? And so the CT renal angiography and DTPA scan helps to take a decision which side of the kidney we need to harvest. And others, the others depends on all the things that I've discussed so far, and it keeps changing. But one thing I want to bring or emphasize now, that because we are talking about the COVID era, now as a protocol, we have the corona testing for all the donors as well as recipient. So for the donors, we are doing the RT-PCR test, but for recipients, we are doing the bronchoalveolar lavage, and that is being sent to confirm that they don't have a corona, because we don't want to do transplant in a recipient who is already having COVID-19, and then the addition or the assault of the immunosuppression would exacerbate his problems further. So we don't want, we really don't want to do that. So who would be an ideal kidney donor? Anyone above the age of 18 years, he should be willing to commit to the pre-donation evaluation process, surgery, and the burden of recovery. He should be a family member, a friend, a colleague, or a close acquaintance of the patient. He should be in good physical and mental health, should have a compatible blood type, and it goes without saying that he should have a normal kidney function. There is also something known as an extended criteria donor. Now, what is the need for this extended criteria donor? Because there is a demand of a lot of kidney transplant, but at the same time, there is a dearth of donors. So extended criteria is so that we can also take more donors, even the suboptimal ones. So any donor above the age of 60 years is considered as part of extended criteria donor, or a donor over the age of 50. He should not have more than 2 of the following. He can be taken up for as a donor if he has a high blood pressure, if his creatinine is greater than or equal to 1.5, or death resulting from a stroke. This is from the perspective of a cadaveric as well. Now, in what all conditions would you exclude a kidney donation? Now, if it's a renal parenchymal disease, of course, we can't take that donor. Conditions that may predispose to renal disease, like recurrent or multiple kidney stones, a hypertension requiring more than one antihypertensive usage. Diabetes mellitus, of course, previously the concept was if the donor is diabetic, we are not going to touch that donor. But now the concepts are changing. The KIDOKI guidelines of 2018 have slightly altered it. Now you can take up a diabetic patient if his diabetes is under control, if he does not have any features of end-stage diabetic diseases like or end organ damage like a diabetic nephropathy, diabetic retinopathy, to just name a few. So if well-controlled diabetic, no end organ damage, then after discussing with the patient, with the family, and making them understanding the pros and cons, of course, the diabetes is also no longer an absolute contraindication. If there is a recent malignancy, I already discussed what are the malignancies, what is the duration for that. An age less than 18 years or greater than 17 years would be considered a relative contraindication. If the patient is mentally incapable of informed decision making, of course, he cannot donate a kidney. BMI more than 35, untreated psychiatric conditions, evidence of coercion, because you need to understand that donation of kidney, liver, or whatever organ has to be voluntary. You cannot force a patient to donate an organ. So there should be no such evidence. If at all there is an evidence, then he should not be taken as a donor. And if he has persistent infection, then he is not fit to donate. Now, does donation of a kidney pose a long-term risk for the donor? Another very commonly asked question. Now, following an nephrectomy, compensatory hypertrophy and increase in GFR, that is glomerular filtration rate, occurs in the remaining kidney. Of course, there is a slight risk of proteinuria and hypertension, but meta-analysis have been done from pooled data of multiple randomized controlled trials from donors, and these have been followed for more than 20 years, and this has confirmed the safety of kidney donation. One more question that we, of course, get asked, but I'm not added a slide for that, is that how cost-effective would be a kidney transplant? No, many studies have been done on this, and in the long term, when you compare the whole duration, a patient who is on dialysis is going to end up paying more than a patient who is on transplant. But of course, with transplant, the thing is you have to cough out that cash immediately. Now, matching between the recipient and donor, this is mainly the domain of a nephrologist. I've just included it, so I give it a completion. So determination by 6 antigens located on HLA gene on the short arm of chromosome 6. Class 12 antigen is HLA-A and HLA-B. They are expressed on the surface of most nucleated cells. Class 2 antigen, which is HLA-DR, expressed on the antigen-presenting cells and activated lymphocytes. These 6 antigens are referred to as the major transplant antigen. Cross-matching is done where the donor lymphocyte is mixed with the recipient serum to see whether the recipient reacts to the donor, and if it does, if it's a positive cross-match, we reject it. Compatible ABO blood group, of course, that's needed if possible. Otherwise, we go for ABO incompatible as well. Now, this is the contraindication to renal transplant from the perspective of a renal recipient, that whom we cannot accept as a recipient. Now, if the recipient also has a recent or metastatic malignancy, active infection, AIDS, like I have already discussed, we have done HIV positive case. So it was not a full-blown AIDS. So the criteria I've already mentioned. So if he fits all that criteria, we can take him up. Severe extrarenal disease like cardiac, pulmonary, hepatic, of course, if he has this, then he has to go for a combined transplant, like a liver or kidney transplant. Acute vasculitis or glomerulonephritis, if there is a possibility of non-compliance to treatment, because if he stops taking the medicines that are going to be prescribed for him, so because he is going to be on lifelong immunosuppression. So if that is not possible, then again, doing a transplant would be futile. And psychiatric illness, alcoholism, drug addiction, primary oxalosis, persistent coagulation disorder, age more than 70 years. Coming on to the surgical aspects, now what is being on display here is a donor positioning. Now this is the lateral decubitus position, right lateral decubitus position. This is the posture for a right-sided donor nephrectomy. You can see that the lower leg is flexed, the upper leg is kept straight. There is a pillow between the upper and lower leg here and here, so that the pressure points are cushioned. Now there are bandages are applied so that the patient is held in position. Of course, on the posterior side or the back side, there would be again some supporters which are not here on display. The patient would be catheterized. This is not a catheter is not being on display in this image, and this would be the area of interest. The umbilicus would be exposed, and this is the starting position. Of course, I need to mention that before we take up this patient, overnight he is kept on fasting. He started on 100 ml of normal saline every hour so that he is adequately hydrated. This is maintained, the fluid balance is maintained intra-op as well. This, of course, is done by the anesthesia team so as to ensure that the patient has a urine output of 100 ml per hour. Now, regarding port placement, the port marked as number 2 is the camera port, which would be a 10 to 12 trocar, and this would be the eyes of the surgeon. Assistant would be showing the camera using this port number 2. Then there is a trocar placed at port number 3, which is a 5 trocar, which would be the left working hand of the surgeon. Number 4 would be the right working hand of the surgeon. This would be again a 10 or to 12 port. So the surgeon uses the port number 3 and 4. The assistant who is showing the camera is using port number 2. We first resect the line of told, enter the retroperitoneum, dissect the ureter, first identify the gonadal vessels, identify the ureter, keep dissecting up to the renal hilum. The renal vein tributaries are identified, which are the adrenal, gonadal, and the lumbar vessels, which are identified ligated clip. You identify the renal artery, the renal vein, and sometimes when we reach that stage, we need a port. So this is marked a bit more laterally, and our exact location would be somewhere around here at this point. So this port is used by the assistant to retract up the hilum so that it's easier for the surgeon and both his hands are free. So he can keep working using port number 3 and 4, and he is not focused on retracting something. So once we do all that, we finally make an incision lower down in the abdomen, which is a Pfannelstein incision. We divide the fascia, the muscles, and finally we reach the peritoneum. Of course, we don't enter the peritoneum at this point of time. Once we have done this much, we go back. Now, once we have gone back, we finally click the renal artery, the renal vein, the ureter, and these are divided. Then we finally go back here, the peritoneum is open, the surgeon inserts his hand through this incision, and the kidney is pulled out. This pulled out kidney is finally collected in a tray, which would be like this. So this is after the bench preparation, but exactly when the kidney is harvested, there will be a lot of fat here, which will be the Gerota's fascia. So this is the ice. Now what you can see is the mop. So we finally start the bench preparation. Now for bench preparation, we first identify the renal artery. We insert a cannula into the renal artery. We start the perfusion with the HTK solution, to which we add 2000 international units of heparin. A good outflow, clear outflow from the renal vein is noticed. Then we, or what all clips we had applied during the lap surgery, we remove clips and we use sutures, ligate this because the clips will interfere with the anastomosis on the recipient side when we go to the recipient side. So finally, the renal artery, the renal vein, the ureter, everything is dissected. The Gerota's fat or the fascia is removed. And finally, we go to the recipient side. One more thing I want to mention is that let us say there are multiple arteries. Let us say we did a CT angio and it showed that the recipient had, the donor had 2 arteries. So what do we do? If the difference is not much, let us say the ratio would be 7:3, 70-30, around 50-50 or 60-40 ratio. In that case, we can make a pajama. So this is known as the pajama anastomosis. So here you can see that these are the 2 arteries of the donor. We are anastomosing both, just like the pant or pajama. So what you can see here is that this donor kidney had 2 arteries. We anastomose just like we would do in a pajama or a pant. And this is finally anastomosed to the internal iliac artery. And this is the renal vein, which is anastomosed to the external iliac vein. Coming on to the complication rates, the older literature mentioned the complication rates of approximately 17%, but Johnson and Associates reported a complication rate of 8.2% in a recent study in 871 patients. The major complications included wound infection, which was 2.4%, pneumothorax, transient thigh paresthesias. Open conversion rate was 1.8%. In our last 25 cases, we had 2 open conversions. Let me also emphasize the fact that though I've already discussed about the donor side, it does not mean that this is the way we do it. We start the recipient around 45 minutes once we are 30 to 45 minutes once we are into the donor. So with the recipient, we start with the classic Gibson incision, which is an incision on the right flank. It's a curvilinear incision which starts lateral to the rectus abdominis muscle at the level of umbilicus, goes down and medially. Then we go deep. We dissect we go deep through the subcutaneous fascia. Then remove the fascia, retract the fascia anterior to. We divide the fascia anterior to the rectus, and lateral to the rectus muscle. We split the muscle so that we enter the retroperitoneum. And once we enter the retroperitoneum, this is exactly how a renal recipient bed would look. So this is the external iliac artery as well as the external iliac vein. And this is the point where we are going to do the anastomosis. Of course, there are centers which are also doing anastomosis to the internal iliac artery. We also used to do anastomosis to the internal iliac artery. So we had some certain criteria for choosing the external and internal iliac artery, but of late, at least in the last 25 cases, we are just focused on the external iliac artery and external iliac vein. So how would the vascular anastomosis be done? So you can see the bulldogs are applied on the artery using a number 11 stab knife. We put a stab incision. So when we put a stab incision, this gives us a space so that we can insert the aortic punch. The aortic punch is inserted into the external iliac artery, and so that a proper round shape rent is created. Now, once we do that, we anastomose the renal artery to the external iliac artery. Now, this is done using a 6-0-proline or a CV7 suture. After we have done that, we anastomose the renal vein to the external iliac vein, which is done using a 5-0-proline or CV6 suture. Of course, there is a lot of variation in this. Some people prefer to do the renal vein first, followed by the renal artery. Now, once we have done both the renal vein and renal artery, and we unclamp the patient, so at that point of time, whenever we see a gush of urine, generally that happens within the initial 5 minutes itself. That's a wonderful feeling, especially considering the fact that you have spent so much time there. The beauty of this is that about renal transplant is that we get to know the result immediately, especially in such cases. Of course, there are things that can still go wrong in the postoperative period, but that's a wonderful feeling to see the gush of urine immediately once you have done the anastomosis. Once you have done all that, then finally we go to the bladder. And this is the detrusor muscle is divided, and you can see the bladder mucosa popping up. And once the bladder mucosa pops up, of course, before that, we fill the bladder with saline so the bladder is adequately distended. And finally, we give an incision on the bladder, divide the detrusor muscle, the bladder mucosa pops up, and we do an anastomosis of the ureter to the bladder mucosa, and we make sure that we insert a stent. We always do stented uretrovesical anastomosis. This technique is known as the Lisch-Grigor extravesical anastomotic technique. So finally, it would look something like this, which would be a renal artery anastomosed to the external iliac artery, the renal vein anastomosed to the external iliac vein, and the ureter anastomosed to the bladder using the Lisch-Grigor technique. If we actually go to the patient's picture, this is how it would look. Both the atrophic native kidneys are in situ. We don't interfere with that. We don't touch that. It is atrophic. And now you can see a well-functioning, fresh kidney in the right iliac fossa. Like I had shown, the renal vein anastomosed to the external iliac, the renal artery anastomosed to the external iliac artery, and the ureter anastomosed to the bladder. And of course, there is a side pic showing a stent in situ. What would be the vascular complications? So I'm not going to dwell too much into the complications, but just to complete it. So there would be a renal vein thrombosis, would be a renal artery thrombosis, renal artery stenosis, lymphocyte, DVT, or a hematoma. Urological complications would be a ureteral leak, ureteral stenosis, urinary calculi, or urinary retention. So the Oxford Dictionary gives the definition of hero as a person who is admired for their courage, outstanding achievement, or noble qualities. Now, when we look from this perspective, all organ donors, whether it be kidney, liver, all organ donors are hero by default. And this is the green ribbon charm. The green symbolizes the hope for those who are waiting for a second chance at life through transplantation. And it reminds us of the men, women, and children who have died waiting for a life-saving transplant. Now, if we really talk about just like I have mentioned, what is the definition of a hero? If you really talk about how they can make a change in someone's life, this is Angela Dunn. She is the oldest surviving kidney transplant patient. Now, she had a transplant at the age of 24 years in the year 1970 in France. Now, that kidney is still functioning for her. This is the year 2020. This is her image in the year 2020. She is still alive and kicking. look at the change in the quality of life, change in the perspective that has been brought about to in her case by this transplant. Of course, we also had a healthy child born to a female transplant recipient 3 years after a successful engraftment. And imagine the joy of the mother in this case. So, once again, I'm really humbled because of the opportunity given to me by IMA Dwarka branch to bring this presentation before you. I hope I have added something and enriched you regarding about renal transplant. Really appreciate this opportunity. Thank you.
Thank you, Arun. That was an excellent talk. You have covered actually almost all the points which are there. I have still, I note that we have got about 3-4 minutes of time allotted to us. I have been through the chat box. I don't find any questions here. I'll ask you 1 or 2 questions which are related to your topic. So my first would be that when you have the potential for kidney transplant, when do you and how do you
Can you come again? I lost you.
I'm asking you.
Hello.
In your patient.
Yes, sir.
Arun, can you hear me?
Hello.
So I'm asking you.
Yes, sir. I can hear you with some.
Okay.
Hello.
Try again. Are you hear me now?
Sir, there is a lot of echo and disturbance.
Okay, let me try again, Arun. Can you hear
me
now?
I can hear you. Yeah, I can hear you.
Okay. So I'm asking you, in your protocol for the recipient, how do you test whether the bladder and the lower tract is all right to go ahead for transplant, or does he need any special tests?
So we, as a routine, are now doing tests in all the patients. So the first essential thing is what is his urine output. Now, if he is passing a sufficient amount of urine, let us say he is able to pass at least 150 ml, we of course ask for a uroflowmetry to begin with. Now, if the uroflow is fine, we don't really go for further evaluations. Of course, if it's a male patient and above the age of 50 years, we ask for a PSA as well because we want to rule out a prostate cancer. But if there are issues with this uroflowmetry, or if there are certain issues with this upper tract changes, or we are suspecting, or if there is a patient who was a case of, like recently we had a patient with a posterior urethral valve. And in such cases, of course, we ask for a urodynamic studies and MCU as and when, depending on the patient profile.
Thank you. And we still have another minute, so I'll just make a comment rather than any question. As you brought out correctly, the real hero of this exercise is the living donor. But as you have probably mentioned in that slide, we don't want heroes. We actually want to look at more cadaver transplants, unfortunately, which are not happening in North India, especially in Delhi. And I would just like to highlight the efforts of some organization. Most notably was the Mohan Foundation, chaired by Dr. Sunil Shroff. And the efforts of this single institute has actually resulted in the union government modifying and adopting NATO as our framework of doing organ transplants all over India. And in recognition of his work, his landmark achievements in organ transplants and promotion of cadaver, Sunil Shroff was honored as a Karamveer by Amitabh Bachchan on his show of Kaun Banega Crorepati. So I think as doctors, we have to promote this in a strong way and use cadaver transplantation as the way to go ahead. You may note that in Tamil Nadu last year, the number of donations from cadavers exceeded live donors for the first time in India. So with that, I'd like to conclude this talk. If there are any other questions, we have half a minute. Anything else? Dr. Subhash, would you like to add something, sir?
No, sir. You have nicely summarized, and he has so simply presented a complex procedure. It's a great presentation. And I think people like us who are novice to this aspect would be highly enlightened. Thank you very much. Thank you, Dr. Arun.
Thank you, sir. My pleasure.
Back to
thank you.
Asha.
Thank you, Dr. Subhash Seth, sir, Dr. Arun. Dr. Aditya, now time to move for second topic. The second topic is chronic liver disease, management and optimization of patients. And the speaker is Dr. Amardeep Yadav. And the chairpersons for this session is Dr. Piyush Ranjan. Dr. Piyush Ranjan is Vice Chairperson, Department of Gastroenterology in Sir Gangarang Hospital, one of the renowned gastroenterologists in Delhi. Proud to have him in a Dwarka family, sir. And the second chairperson is Dr. Rakesh Pandit. He is Senior Consultant, Internal Medicine, Akash Healthcare, one of the most respected physician in Dwarka. So I welcome both chairpersons and to conduct the session. Thank you. Dr. Piyush, sir. Dr. Piyush.
Amit, can you unmute him because his mic is muted?
Sir has to.
Dr. Piyush, sir, please introduce the speaker.
I'm unable to unmute myself. Just give me a minute.
You are audible, sir.
You
You're
are
audible.
audible, sir. You are audible.
Am I not audible? I have unmuted myself. Is it?
Sir, you are audible.
You're audible.
I am audible. Okay, right. So good evening, everybody. We begin with the second topic, going ahead with the first renal transplant. The topic is chronic liver disease management and optimization of a patient. So the presenter is Dr. Amardeep Yadav. He is a consultant in Venkateshwara Hospital. He has done his graduation from Rohtak, if I am not wrong, and subsequently from his master's from PGI Chandigarh. Subsequently has done his fellowship from Medanta, and he has also trained at King's College. He has done all the complex procedures involved in a liver transplant, has got a vast experience, more than 1,500 patients operated and assisted, previously working with Yashoda, Medicity, and currently in Venkateshwara. So Dr. Amardeep, please go ahead. We are all eager to listen to you.
Thank you, Dr. Piyush. Thank you, IMA Dwarka, for providing this opportunity to present on a vast topic. I will try to briefly discuss the main things because everybody, as a part of their general practice, must have dealt with chronic liver disease patient in some way or other. But I want to discuss this topic because it makes a lot of difference in a patient who especially has a living donor in the family. And in those patients, if little aggressive management can be done, these patients may reach a transplant and they may have a new life. Because as compared to a renal disease patient, a liver patient may not live for long. Like kidney patients, they are almost stable on dialysis for maybe 3 years, 4 years, or maybe longer also. But liver patients, if they don't have anything called dialysis, so these patients, they are like, either they get transplant in 6 months or they die within 6 months, 1 year. So briefly, I'll discuss with the management and optimization of patient. Management includes the pre-op management and the surgical part of it. So my screen is visible, sir?
Yes, sir, it's visible. It's visible.
Yes, sir,
Visible.
Okay. So this is the cirrhotic liver which we take out after transplant. It is not a good looking site. The liver is very bad. The inside of our abdomen is not a good sight to see. It's all bloody, vessels are dilated, everything is adult. And this is the usual patient of a liver disease. You must have seen
in our general practice, a patient who's lethargic, yellow, he is always lazy, lying down, and like our common Indian scenario, they are still taking alcohol despite everybody in the family and medical fraternity doctors telling not to drink, but they keep on taking. They have legs swollen with edema, they have ascites, requiring tapping, and gradually they are getting sicker and sicker. Muscle mass is getting lost and the body is accumulating fluids. Most common cause virus and alcohol still in our Indian scenario and outside scenario also. One more thing is female drinking, which is coming very commonly. And it's not that the female, only thing which I want to bring to the notice is in females, the serogenetic dose of alcohol is very less and they get cirrhosis early as compared to males. So coming to the optimization of recipient, I'll be discussing 2-3 patients which were like tough for in my experience and were little different. Why I want to discuss these patients, because a certain aggressive approach to these patients, it helped them, and these patients could reach liver transplant, and they are like living normal now. So as we all know, these are the common decompensation in chronic liver disease patients. They have ascites, they have a spontaneous bacterial peritonitis, hepatic encephalopathy, upper GI bleed, HRS, HPS, HCC, all those things. So I'm not going to in detail of management of these things in detail, but complex very rarely, but challenging. This is my first case, which I will discuss. She was a 29-year female, ulcerative colitis, total colectomy done, but still having primary sclerosing cholangitis. She had biliary sepsis, and on ABG, she was having symptoms of hepatopulmonary syndrome. When she was referred on NIV, on BiPAP, and in ICU, the intensivists, they were ready to intubate her. And because the oxygenation was very scary, it was very low, despite giving her whatever oxygen, her oxygen saturation was not coming up. And as you know, that ulcerative colitis patient with PSC, they are very sick. They don't have muscle mass. They are like 35 kg, 40 kgs. And if these patients, they are intubated and once ventilator, they become ventilator dependent, and we are not able to take off them from ventilator. So we did all the, and this was the CT chest of this patient, bilateral haziness, room air, oxygenation was 67. Even after 100% oxygenation, PO2 could not be like very exciting, 147. And we treat her with the 4 PTBD. All the 4 systems on the right side and left side, they were drained by a percutaneous tract. The biliary sepsis settled. After the sepsis was settled, her oxygenation improved after 100%, and we were able to take her for transplant without putting her on ventilator, which of course helped us in bringing down the cost of overall transplant and giving her a good result. Second patient, which is very commonly seen in our general practice, alcoholic patient with a severe hyponatremia, repeated episodes of admissions for ascites, recurrent SBP, recurrent HRS because of mismanagement of fluid. Somebody will drain 10 liters of fluid in it. They will not give replacement with albumin, most of the time because of financial issues with albumin. And sometimes they are doing this thing at a periphery where nobody is, mostly albumin is not available, or the doctor is not bothered to replace with it. So this patient, he was managed with multiple episodes. We started on tolvaptans, we started with soda bicarb, albumin, hypertonic saline multiple times. We had required multiple tappings, severe antibiotics, and with treatment of HRS, we could take him to transplant. Case 3, a patient who's 52-year male, he only had right hydrothorax, there was no ascites, liver function, late child B, early child C, require to put ICD repeatedly. Whenever we take out ICD, and within 5-7 days, he will have again hydrothorax on that side, multiple ICD placement because of that thing, pyothoraxes, and he was having multiple episodes of pyothorax on the right side, no other decompensation, and patient was otherwise a case of Budd-Cherry syndrome. We had done tapping, put ICD, drained the fluid over 5-7 days, gradually drained the lungs, and after that we had done dips. We had done a directly interportal shunt, and after dips, the hydrothorax settled down. The patient was fine. He was fine for maybe a month without requiring any ICD placement on the right side. His antibiotics were gradually put down, and then we transplanted the patient, and the patient did well after surgery. So all these things were like little rare cases where it is not seen aggressively treated like this in routine practices. And briefly, which is, I want to bring down this acute decompensation, which the patient was a little stable patient. He was stable on medical management and chronic liver disease, but something happened and they decomposed very fast. And we see these patients as acute on chronic liver disease. We label as ACLF. These patients are rapidly progression. They have multiple organ support required. They have high mortality like acute liver failure patients. But the common definition is still not defined. There are multiple scores which try to define the severity of acute on chronic liver disease. Usually the most commonly cause is alcohol, patient drug-induced, most commonly in our scenario, tuberculosis treatment, superimposed viral hepatitis. So a patient who was stable, but they had acute portal vein thrombosis may also push the patient in acute decompensation. They may have ischemic hepatitis, and there are extrahepatic insults like trauma, surgery for umbilical hernia. They had recent bleed or infection. Liver transplant in ACLF in India, sadly, there is no priority given to these ACLF patients, though we know that these patients behave like ALF only, and they require urgency. If we are like going for cadaver transplant, they should given priority as compared to liver disease patient. But in India, only priority is given to acute liver failure patients, or in a post-transplant where hepatic artery thrombosis is there, only these people get, like the sir was, Dr. Aditya was saying, in cadaver donations states, only these patients get the priority. So acute ACLF patient, they don't get priority for organ in India as of now. Timing is important. These patients, window of opportunity is very narrow. These can get transplant only within a narrow window period. If they are not able to, they are irreversibly unfit for transplant. In long term, they don't have any difference as compared to CLD patients. Even in high MALD, if transplant is done at the right time, they have long-term survival as compared to a routine CLD patients. Briefly about acute liver failure, where we see that the patient in Indian scenario, though we don't have paracetamol poisoning that much common, but yes, it is seen in India also. But in India, the causes of acute liver failure are mostly virus, hepatitis A and hepatitis E. So in these patients, contraindication that the patient is not fit, maybe because of cardiopulmonary disease or sepsis, he is having extra hepatic malignancy, may not be good or technically not possible because of extensive venous thrombosis, or the family or the patient is not willing. So for early successful transplant, early referral is required. Pre-op management should be very aggressively managed, and best is if they have a living donor, the patient should be stabilized, optimized, and then transplanted at the best of the time. So you must all be knowing that two types of transplants, one is living donor and the cadaver transplant, and there are further varieties of cadaveric liver transplant. So briefly discussing about what are the survival rate if you don't transplant a patient of commonly child score patient. If a patient having child score of 5 to 6, child A patient, most of them 90% are surviving at 5 years. But if we see the child C patient, 60% are only surviving at 1 year. So as the child score severity increases, the spontaneous survival without a transplant drastically is reduced. Second common assessment is MELD score, and we see if a MELD score is less than 15, then 1 year and 1 year survival is more than 80%. But as it crosses 15 or 19, only 1 year survival is 2/3, and if it is above 30, only 1/3 of these patients are surviving 1 year. And if more than 35, only 29% are surviving not more than 3 months. So when to list for a transplant, a patient whose MELD score is 15, a child score is more or equal to 9, and there are other criteria also, and severe complication of end-stage liver disease. Even if child score is not 9 or more, sometimes we see a patient whose child score is around 7, 6, but still they have these symptoms like refractory ascites, they have spontaneous SVP coming, they have refractory portal hypertension, variceal bleed, massive bleed episodes repeatedly happening, and they have repeated hepatic encephalopathy. Even if these patients have only one of these symptoms, their MELD score or child score will not be bad. But these patients, they die fast. So in these patients, if some patient is having a low MELD score or even a low child score with having these symptoms, they should be given an option of transplant earliest, because they don't survive for long till the MELD score or CTP score is bad to be listed for liver transplant. When it's too late, when there is active uncontrolled refractory sepsis, there is extrahepatic malignancy, or there are patients are on prolonged dialysis. These patients, they will not suffice liver alone, they will require combined liver kidney transplant. And combined liver kidney, in addition to the cost, the risk also is more, because these patients, they have more tendency to get infection post-op or during surgery. One slide where I want to discuss that where CTP or MELD score is not bad, but still we tell the patient to go for transplant in early course. A patient who's around 60, 61 years, but otherwise stable. These patients, they might be on medical management for 3 years, 4 years, 2 years, and they are fine. They will not need transplant as of immediately. But these patients, if they have a natural course of disease, after 3 years, the risk of surgery at age of 63, 64, 65, it will be more than as compared to the patient at age of 60. So any patient who's like crossing 60 years and little late child B, we tell them go for transplant, because at the age of little later, the risk of surgery because of age-related or other cardiovascular involvement will be more. So they are given an option of transplant in early of this thing. A patient having partial portal vein thrombosis. Why these patients are given an option of transplant early? Because once the partial portal vein thrombosis becomes complete portal vein thrombosis, all the portal vein is thrombosed, these patients are technically not doable. We cannot transplant them, because till we need to have the organ, when they will require transplant, when they have complete portal vein thrombosis, they will deteriorate very fast and we cannot transplant to them. And in case of repeated episodes of bleeding in fundal varices, a transplant is also indicated early, even if the child score or MELD score is less. In general practice, we all must be saying that because of good screening of hepatitis B and C in blood banks and use of disposable areas, hepatitis B and hepatitis C new infections are coming down, and especially with the treatment of hepatitis B and hepatitis C, very good treatment tablets. So these patients in coming years are going to be less. But one more, that fatty liver, because of our food, lifestyle, all these things, it is going to be a big problem in coming time. So we presume that in next 10-15 years, most of the cause of liver disease will be NASH or lean NASH, which is going to be the most common cause of chronic liver disease requiring liver transplant in coming next 10-15 years. Briefly I want to discuss about the hepatocellular carcinoma in cirrhotics. There are 2 criteria which says that these patients should be transplanted if they are fitting within these criteria. But briefly to tell this, that these criteria were made for cadaveric countries like in UK or US, because they wanted to use the organ for the best of possible. So these patients in our India, we don't follow in living donor. These criteria are not followed, because in living donor, the living donor is personal gift to the patient, and we are not doing any injustice to the society. But yes, if a cadaveric organ is in the question, then yes, the organ should be given to the best patient who can have its advantage. A patient who usually don't fit in these criteria, they will have high tendency of recurrence after surgery, and the organ might be wasted. It could have been used for a other patient who could have given him more life. In case of SCC, advantages of liver transplant is underlying cirrhosis is also cured, and it provides the widest oncological clearance of transplant and allows a pathological staging. Sometimes in pre-op CT, there might be only one tumor, which is 3 centimeter, but when we explant in the pathology staging, usually there are 3-4 more tumors, and the patient is actually at an advanced staging. Why there is always that transplant is better than resection in HCC in cirrhotics? Because most of these patients, they will have recurrence within 2 to 3 years, and after 100% of them will have recurrence of tumor after resection. Like Dr. Aditya was discussing, I want to briefly talk about that we should all promote organ donations, because organs are required by us, and the number of patients waiting for transplant are far more than the number of organs available. We started when we started in November last year, our team in Venkateshwara liver transplant team, we had one organ donation within 2 months. We had good start and we had like high hopes, but because of this COVID, our cadaveric program has paused for some time. But hopefully in coming time, our cadaveric program will also pick up, and we will able to generate more organs inside hospital or other hospital with the help of NGOs, which are actively participating with promoting this. Briefly about cadaver transplant, and interesting slide how long the organs can be kept outside. Heart has the shortest 4 to 6 hours in cadaveric program. In lungs, it is 6 to 8 hours. Liver 8 to 10 hours. Kidneys longest 24 hours. Pancreas we have to transfer within 8 hours, and bowel 4 to 6 hours. So this is type of grafts in living donor. Briefly about donor evaluation, in living donor liver transplant, the donor should be 18 to 55 years, blood group compatible. We also do blood group ABO incompatible liver transplant. BMI should be less than 35. Relative of the patient for government authorization committee, they should have normal liver function, their viral marker should be negative, and CT triphasic and MRCP should be acceptable. They should have acceptable fatty liver steatosis. The volumetry, the GRWR should be more than 0.8. The remnant should be more than 30%, and not a very grossly abnormal anatomy. In today's time, anatomy is the least concern for us because of long-term experience that any anatomy we can transplant. Less than 20% fat for right lobe, less than 30% fat in left lobe graft, and remnant of 30%. If fat is more than 30%, transaminitis more than 2 times, inadequate GRWR remnant or abnormal anatomy, we reject the donor. This is an intra-op photograph of a living donor liver transplant. These are the outflow. If you can see the cursor on your screen, these are IVC, these are anosmosis, outflow anosmosis, these are inflow anosmosis, artery, biliary duct, and portal vein. Advantage of living donor liver transplant as compared to cadaver in living donor, that it is an elective procedure, we can plan, and there is a short waiting period. The quality of graft is good as compared to cadaver if it is from an old person or it is not well managed casualty, then the quality of graft may be compromising. Then optimal in function of the transplant patient can be done. control of pre-existing infections, improve nutritional and performance status, less cold ischemia, no competition for donor, it is personal gift to the recipient, and we can go for extended indication like hepatocellular carcinoma, HIV, or HCV. Also, briefly, I want to discuss about early liver transplant in case of CLD patient. Because in long term, the more the patient is medically managed after a certain time, and they are not told about transplant or they are not willing for transplant, then a lot of money being wasted by them. And the patient also keep on deteriorating. By the time they reach transplant, they don't have muscle reserves, and their post-op recovery is slowed, and they need, ultimately, if we see, they end up spending more money on transplant and overall medical management if they would have gone for transplant early in the disease course. So in management of end-stage liver disease, a bumpy road, it's not a smooth road. Sometimes patient will improve and sometimes they will deteriorate, but gradually the course is downhill. In Indian context, what I have seen is the small improvements in patient condition after a hospitalization. They feel they are recovering, and then they further delay the approach or getting surgery done because they feel that they are getting well after medical management and they don't need any transplant or any management, only to go to ICU next time. Thank you. Thank you, sir.
Dr. Piyush, you're there? Okay. Dr. Amardeep, thank you for nice insight into the liver transplant. I, being an internist, I have a lot of CLD patients and I'm perplexed that what to do next. And I think it's a nice, I also understood a lot of things about transplant today. And we have some situations where I recently had a patient who had both CKD and CLD. Do you have you come across a patient where you have done a double transplant or?
Yes, sir, we have done transplant, not in Venkateshwara, but in my previous institutes, we have done quite a few number of dual transplants, combined liver and kidney. Most of these were having auxiliaria as a cause of kidney disease, and simultaneously they had liver disease.
Yeah. And second thing is nowadays I deal with a lot of COVID. I am seeing I have recently one patient admitted post-transplant in April and he has COVID. He had bad COVID. So it's a bit difficult for us to manage these type of cases, though we have, his COVID part is better and transplant type, we are getting the advice from the transplant surgeon and that team means he was operated somewhere else. They didn't have beds, so we accommodated him. And it's a very difficult scenario for us also to treat it.
Yeah, it is a difficult scenario, sir. We have transplanted a patient recently at Venkateshwara who had COVID positive and he was shifted here for management. He was shifted for medical management transplant, but on admission he was found to be COVID positive. And we waited for 3 weeks for him to become COVID negative. Then we waited for 4 weeks for repeat COVID negative, and then we transplanted. And he had a good transplant post-op. So, and in other friend circle, like our other friends, they do have this COVID issue. After surgery, they become positive for COVID after going home. But somehow these patients, 50% of them, they are asymptomatic. They are like normal population. It doesn't matter they had transplant or they are immunocompromised. The COVID is causing different symptom. But yes, of course, like 50% of them, they become very sick and they don't make it.
Yes, we had one. He was in AKI and he had a bad COVID. He was on NIV and then he had D-dimer more than 10,000. But luckily that part is over. But now transplant part, that is being looked after.
It is too early to say how these immunocompromised patient will behave with COVID. Nobody knows. Some of them, they do very good. Some of them, they were like doing very good and suddenly they just die.
Yes, one of the treating physicians had given us an advice of plasmapheresis for his low platelets, but we were a bit reluctant. I don't know.
I don't know, sir,
Because
about
all
plasmapheresis.
antibodies, we also have no idea and how to deal with this, because this many people have not encountered. This means they do plasmapheresis, take out all antibodies, chances of sepsis. So we are a
But
bit in
plasmapheresis in our scenario, sir, in post-transplant, they are going to be septic. All of a sudden, our hospitals are very, we cannot help it. They become septic even after 1 or 2 plasmapheresis.
Yes. Sir, over to Piyush, sir. You're here.
I'm listening to it. Dr. Amardeep, very challenging cases you presented initially, patient with ulcerative colitis, PSC. So I'll just ask you a few questions for the clarity of the audience. In ulcerative colitis patient, you did a simultaneous colectomy?
No, sir. Colectomy was done previously. Even after colectomy, she developed PSC after 1 or 2 years of colectomy.
So that is a known thing, that in a patient with PSC, if you do colectomy alone, the acceleration of the PSC gets accelerated, right?
Yes, sir.
And it would be worthwhile pointing out that in PSC, you would do a bilioenteric anastomosis, which again has got a little higher rate of complications than the usual duct-to-duct anastomosis, right?
Yes,
and regarding hepatopulmonary syndrome, what is the cutoff which you take, I mean, of the pulmonary artery pressure for taking up the patient for transplantation? In this particular patient, in the first patient which you presented.
Yes, sir, we don't do any pressure for hepatopulmonary syndrome. We do, if patient is having pulmonary hypertension, that is different thing. If the patient is having oxygenation less than 70%, we suspect HPS, hepatopulmonary syndrome, in these patients, and we do testing of with 100% oxygen. Obviously, in addition to the mass scan, MA scan, we document the percentage of shunt in the lungs for prognostication. But for practical purpose, what we do is we take the patient to the OT, we give them 100% oxygen, and we see the reversibility of the SpO2. If it is more than, like the SpO2 after giving 100% rises above 200 points, then we take the patient and we presume that the patient will recover after transplant. If even after giving 100% oxygen, the oxygenation is not good, then we usually are not taking the patient for surgery, because we have encountered one episode where the patient was not having this kind of thing, and we had a difficult time after giving anesthesia to the patient. For pulmonary artery hypertension, if the pressures are high, if the PSP is more than 35 and they are not reversing after diuresis and decongesting, we usually don't take the patient for transplant.
Right, but all patients with HPS will have some degree of pulmonary hypertension. Anyway, there is a question from audience. Let me take that first. In child B patient doing well on medications, how long should you wait? This is a question from Dr. Paras Kathuria.
I think in what my practice is, sir, we don't tell them to go for transplant straight away. We tell them that you are in child B and coming time, it may be 1 year, it may be 2 years, 5 years. As you approach child C, you will need transplant. So you just have to be followed under us, and once the patient is entering into child C, or one of the complications which I mentioned, it started happening in that patient, even if they are in child B, then we offer them for transplant. So if these complications are not happening in that patient, and patient is on medication stable in child B status, okay, we wait till the patient, one of them, they become complicated, or they...
Child B is a huge spectrum, so you can have high child B, you can have low child B, child B and C, depending on the reports, ascites, they can be, patients can be shifting from child B to child C status, and optimization obviously means medical treatment. Nutrition you mentioned, there is a lot of data now coming on sarcopenia in patients with cirrhosis. That is a very important aspect, taking care of their nutrition. And with the availability of good antiviral drugs, stress on relieving the risk factors for NASH. We have had now upcoming data on pre-op bariatric surgery in early child cirrhosis for reversal of NASH-related cirrhosis. And you mentioned two particular things, partial portal vein thrombosis and fundal varices as early indication for liver transplant. When partial portal vein thrombosis, you would, in a patient who has got complete portal vein thrombosis, you would anticoagulate, try to open up radiological procedures. Now there are a lot of intervention, radiologists opening up, doing a percutaneous direct access and thrombolysis, or accessing through the hepatic veins and doing a local thrombolysis. So partial portal vein thrombosis is not a very standard indication.
So
for
what
this.
partial portal vein thrombosis means, if the patient and the lumen is blocked more than 50% and there is sign of calcification in portal vein thrombus. It's not just acute thrombus, which is I'm talking about. It's about like chronically thrombosed vein, because in long term, if the calcification has started, these patients, they will gradually, the portal vein will go atrophic. It will completely thrombose. There will be cavernoma formation. I'm talking about those patients, chronic portal vein thrombus, not acute thrombus. Acute thrombus,
chronic
I
portal
agree.
vein thrombosis patients will have collaterals, and there is a.
So sorry to interrupt. Can we have a question answer after the third session, sir?
No. We can close it here. There is one more question from one of the panelists, attendants, delegates. From one liver cadaver, how many transplants you can do? We'll close it after this.
So it depends. If we have suitable recipients with ideal weight, we can split the liver and give it to two patients. But the left lobe can be given to a patient like I discussed, ulcerative colitis patient, and they having weight of 40, 45 kg, maximum 50 kg. We can give the left side to them, and the right lobe can be given to a bigger adult like 70, 80 kg. But if the recipient is like not matched, we have a pediatric and an adult. We can give it. We can give the left little to the pediatric recipient. So maximum we can give it to 2 if we have a ideally matched recipients in our list.
Thank you. So these were the questions from the delegates. There are a lot of questions. Liver transplant is a complex procedure. Thank you, Dr. Amardeep, once again for this wonderful presentation.
Thank you. Thank you, Dr. Amardeep, for such a nice and crisp talk. And thanks to our chairperson, Dr. Piyush Ranjan and Dr. Pandit, for taking out your precious time. Now we are moving to the third and last topic, breast cancer in India and treatment challenges. The speaker is Dr. Sunil K. Gupta, and the chairperson for this session is Dr. Neeru Kiran Banerjee. I think everybody knows her in West Delhi. She is a renowned gynecologist in West Delhi, chairperson of Gynae Forum for so long, I don't even remember, and past president of IMA Dwarka, very charming personality. Dr. P, and the second chairperson for this is Dr. Piyush Bajpai. He's a senior consultant oncology department, Manipal Hospital. He's a prolific speaker, and he's always admired by the audience. So I'll invite Dr. Neeru Banerjee and Dr. Piyush Bajpai to conduct this session.
All that is important.
Namaste.
आज मार्केट कहीं में भी जाओ ना तो ये करके भी डिस्प्ले
Dr. Neeru Banerjee? Dr. Neeru, ma'am? Dr. Piyush, are you there?
Yes, ma'am.
Okay. And Dr. Neeru, ma'am? Dr. Neeru, ma'am, are you there? So, Dr. Piyush, will you introduce the speaker?
Well, it's a great pleasure to introduce Dr. Sunil Kumar Gupta, sir. And he is heading the medical oncology department at Venkateshwara Hospital. And needless to say, we all know him. We have heard him earlier as well. Dr. Gupta did his DM Medical Oncology training at Cancer Institute, Adyar, and happens to be my institute as well. So glad to be here hearing from him. And he underwent fellowships at world leading cancer institute at Fred Hutchinson Cancer Center and Seattle Mount Sinai School of Medicine, MSKCC, and then MD Anderson Texas Institute, and then multiple other institutes where he has had his training. Well, he is an expert in treating solid tumors and hematological malignancies and doing transplants. So welcome, sir, and I hand over this to you for your further talk. Thank you.
Thank you, Piyush. Very good evening, dear friends, ladies and gentlemen, and respected chairperson. At the outset, I really thanks the IMA Dwarka who has given me this opportunity. And today I have not giving a clinical picture of a breast cancer, but I am giving a talk which is very important for my colleagues, because this is an eye-opener for all of you, that what is the trend in India and what challenges we are facing in a breast cancer management, because in a metro cities like Delhi, Mumbai, Chennai, and even the Tier 1 city, breast cancer is a leading and surplus to the cervical malignancy. So my talk is basically focused on a breast cancer in India and treatment challenges in a present era of 2020. But before that, I just want to show you how I will proceed in my talk. My talk is basically focused on breast cancer, the healthcare challenges in India, even in 2020, increasing incidences of breast cancer despite of multi-modality treatment, we have a mortality rate. What is the epidemiology of India in the cancer registry in the different areas like Northwest, East, and what is the key barrier of a breast cancer treatment in India, whether it is affordability, accessibility, or awareness. I would like to address all the issues, and way ahead, how do we address challenges of breast cancer epidemics in present 2020s era. So if you see the breast cancer incidence as per the Globocon predicted that India cancer burden will be double in next 20 years. This is an alarming situation for all of us, because already in a metro cities like Mumbai, Delhi, Chennai, and other tier cities, the breast cancer is leading as a #1 cancer is women. And projected cancer cases in India are slated to rise from 1 million patients in 2012 to roughly 1.7 million in 2035. And this is again an alarming situation, because we are talking about an advanced medical multidisciplinary approach in breast cancer, and despite of that, the incidences and mortalities will be high in future. Estimated number of cancer related deaths are also projected to be increased from 0.68 million to almost double, roughly 1.2 million. And this is again an issue of a worry for medical fraternity. So emerging key issues and challenges in breast cancer management, I am just giving a gross picture to you. One side there is a world, I am giving only 3 countries, India, United States, and China. If you collect all these 3 countries, 1/3 of a global breast cancer burden is seen only in 3 countries. Rest of the world is separate. Roughly 30% or 33% patients of breast cancer are from India, United States, and China. And the challenging situation in breast cancer during 2008 to 2012, I'm just showing the picture, 11.54% increases in the incidence of breast cancer. And despite of talking about a modern science, modern surgery, modern medicine, modern radiation, the increase in mortality in the tune of 13.8%. So reason of increasing in incidence and mortality, I'm just discussing in brief that how the metro cities are leading because of urbanization, westernization in women, changing lifestyle, late marriages, no breastfeeding, junk food, alcohol, smoking has lead breast cancer to attain the top position in all major urban registry in India, specifically Delhi, Mumbai, Chennai, Bangalore, and Calcutta. Population growth and aging affecting almost all part of India. I will give you the cancer registry data to you, that how this reflect the things in India. And mortality again very high because of lack of inadequate breast cancer screening, leading to diagnosis of diseases in the late stage, especially locally advanced disease or stage 4, because our country is not having any screening program as like the Western world. appropriate medical facility limited to metro cities or tier 1 cities only. In B and C class cities or small town, we are not having any infrastructure even to diagnose the breast cancer, even in early stage. So I would like to discuss the epidemiology of breast cancer in India. And this is not from one cancer registry. This is the total India cancer registry, which is giving a picture, and this paper is published in journal. I'm just giving two idea regarding that in 2012, almost 1,45,000 Indian women were diagnosed of breast cancer. And in 2009, breast cancer became most frequently diagnosed form of cancer in Indian women. And I just showing the bottom is #1 cancer in metro cities and tier 1 cities. And now I am showing the 5-year trend of breast cancer among registry. And I'm comparing the rural area like Varsi with the industrial cities like Bhopal and metro cities like Delhi, Chennai, Mumbai, and a tier 1 city like Bangalore. And just see in the top, the capital of India is having a top number in breast cancer, is leading, followed by Chennai, followed by Bangalore, and then Mumbai. And the Varsi, the rural area, is having the bottom, is having the lowest number of breast cancer patients because of our culture, early marriages, breastfeeding, no junk food, and other things, which leads that even today, present era, Varsi or rural area is having a low number of breast cancer patients. If you see the population-based cancer registry showed a statistically significant increase in ARA of 1 lakh population over time. So what are the trends? What are the trends in 5 years as per the age distribution of the women? I have seen in my clinical practice roughly 3 decades back, people are talking about most of the cancer in women are post-menopausal. But the trends are now changing. We are having the young patients. And I'm not talking about only the metro cities. I'm talking about the northeast area also. They clearly mention about that. Studies suggest that the disease peak is at the age of 40 to 50 years of age in Indian women. And this peak is more important. I have seen that this is roughly 10 years prior to the past in a present era. And our young women are suffering more with the breast cancer. Now I'm comparing the age distribution in triple negative and hormone positive versus hormone receptor negative tumor. If you see both these segments, the both subtype has a peak in the age of 45 to 49 years of age, and the bars clearly show that this is the age of a postmenopausal phase, and most of the women are having breast cancer in this age group. But if you see the triple negative patients, those who are young, roughly 10 years prior to that, and triple negative patients are more in India as compared to Western world, which clearly mention about the age of 30 to 34 years of age and clearly shown by the bars. But the things which I want to convey you, that triple negative breast cancer is rarely seen by the data after the age of 54. This is basically on the basis of population-based cancer registry by the different part of India. Proportion of distribution of subtype of breast cancer. We are talking about a receptor positive breast cancer, means hormone positive, hormone receptor positive, triple negative breast cancer, or a hormone positive or hormone receptor negative, or all 3 receptors positive patient. Roughly triple negative patients are 1/3 of all tumors, which we have seen by the registries, registration and retrospective analysis. And just see, roughly 46% patients are hormone positive. Hormone positive means estrogen and progesterone receptor positive, and hormone negative means. And 33% patients are basically the triple negative patients, and hormone negative means ERPR negative, but hormone receptor positive patients are seen 13%, while all 3 receptors positive, I mean to say that estrogen, progesterone, and hormone receptor positive patients are seen in the tune of 8%. And every subset of patient is having a different treatment as per the age, as per the other pathological risk factor in clinical practice. So key features of breast cancer in India, I would like to convey you very clearly that in India, in a present era, India incidence of breast cancer is increasing in young women. And we have seen roughly 10 years prior to that, more breast cancer patients. And these patients are basically triple negative in our clinical practice. Young patients are basically triple negative and basically have a disease recurrence despite of multidisciplinary approach within 2 years. And these patients are having a visceral mets as well as brain mets and bony mets in a short period. And there is no standard care till date. We are searching which is the best treatment option for triple negative patients till even 2020. Prevalence of triple negative in India is considerably higher compared with the Western world, which I have mentioned you very clearly that India is having a more triple negative patient, more young patient. Frequency of BRCA1 and BRCA2 genetic mutation was reported in many studies ranging from 2.9% to 24% among Indian families breast cancer patient. And we are doing this test on a day-to-day basis if there is a family history. 45% of the breast cancer patients are diagnosed in advanced stage because we are not having a screening program or any government program which can detect the disease in early stage. We are talking about a cell breast examination at the age of 20, but India, due to lack of awareness or lack of communication, nobody is doing the cell breast examination even as a screening method. If you see the mortality rate as per the population-based registry, 70,000 Indian women dies of breast cancer is the estimated estimation given by the population-based registry. And just see, this is again on the bottom of the curve, clearly showing that breast cancer incidences and mortality is really a question of worry for all medical fraternity because this is the leading cause of death in our scenario. Breast cancer in India prevalence, just see again, this is on the top to bottom side, just see breast cancer is number 1. Roughly nearly 4 lakh of these who had reportedly been diagnosed as a breast cancer patient in last previous 5 years were still alive. This means we have improvement in our treatment part. We are talking about a surgical, medical and radiation management. We are talking about a targeted therapy. We are talking about a more sophisticated way to treat such patient, and that's why there is a 5-year survival despite of advanced stage and locally advanced disease. So what are the 3 cardinal features of a clinical epidemiology of breast cancer in India? Number 1 is a presentation for medical care at the late stage. I clearly mentioned that even in a small cities or a small town or a district level, even at a B-class city, the facilities are not
Dr. Amarpreet, unmute yourself. Dr. Amarpreet, mute yourself.
So presentation for medical care at a late stage, this is the reason in India that roughly 45% patient presented to us in a locally advanced disease or in a metastatic disease, and we are talking about a palliative care or a less survival as compared to the early stage. Second thing is a lower median age at the first diagnosis. Now we are having a young patient, triple negative patient. Triple negative breast cancer patients are basically having a tumor which is totally recurrence seen despite of a multidisciplinary approach within 2 years or in a 5 year, and common sites are the visceral mets or a brain mets or a bone mets. Third thing is a high proportion of a hormone receptor negative and triple negative patient. Even hormonal negative patients are not responding well. They are responding initially well to the chemotherapy, but the recurrence rate is very high. And these are the 3 cardinal features which clearly show that this is a reason of a great mortality in India. Now the question is, what are the challenges we are facing in our clinical practice as a doctor? So if you see the regions which clearly mention about affordability of the treatment, we are talking about a multidisciplinary approach. Cancer treatment is really expensive treatment, and regarding the accessibility as well as awareness regarding the treatment, the 3 key barriers that are limiting the diagnosis and treatment of cancer patient in India as per our population-based registry. The cost of cancer care treatment in India is 5 to 6 times lower than the United States. still unaffordable for a large section of a society, owing to because of low coverage of public and private institution programs, and roughly 30% population covered only that. Low average household income level, with roughly 20% household with annual income less than 3,500 US dollar per annum. Second thing is a low access to physical and diagnostic and treatment facilities at district level or a B class city, and human infrastructures. Low density of qualified oncologists at small cities or a B class cities or a district level or a periphery. Significant geographical skew, infrastructure limited to metro cities or a tier 1 cities. Most of the comprehensive cancer centers you can see in a metro cities or a tier 1 cities, or now there are slowly picture is changing in even in a B class city. Awareness regarding the disease, symptom and screening is low. We are not having any specific program as per the government. We must have this. Ex breast cancer studies in South revealed that roughly 50% of the patient heard about the breast cancer, and 80 to 90% are not aware about that, and even they are not doing the self breast examination on day-to-day basis. So reducing incidence and mortality of breast cancer patient in India, what we can do and what we can do as an effective manner. Increase awareness of breast cancer. Like today program, I have selected this topic because we are talking about so many times regarding the breast cancer treatment. These are the chemotherapy, these are the targeted therapy, these are the surgical way, this is the radiation therapy. But we never talked about the magnitude of this disease in India and outcome, and even the projection of a future disease outcome and an incidence. Today I'm just discussing as an awareness program that increase awareness of breast cancer even in community, even in B class cities or in a small city, increase community based awareness of breast cancer. This is very, very important for IMA point of view. Preventive measures and screening program for early detection. Again, this is from IMA point of view that we must have camps where we can go for a preventive measures and a screening program for early detection of breast cancer. Understanding breast cancer better, we must discuss the data, the protocol-driven decision making, the world's guideline, what are the guidelines and screening program of a Western world or United States. Use of genomic tool for early diagnosis and guided treatment. In metro cities and tier 1 cities, we have all the infrastructures. But what about the B class cities and the district hospital or a periphery or PSC? Collaboration with Center of Excellence. You can contact the Comprehensive Cancer Center where the team of doctors are working, or a multidisciplinary approach, or you can take the help of the pharmaceutical industry or a governments from the state point of view, state government point of view, or a central government point of view, or a NGOs. Share best practice by the guidelines like NCCN guidelines, or by the Western world guidelines, or the NICE guidelines. Access to treat, the patient assistance program, supporting treatment, increasing insurance coverage. Sometimes there is a problem even in insurance for a targeted therapy like immunotherapy, and those patients, those who are hormone receptor positive, insurance companies are not providing support. They always say immunotherapy is not covered by the insurance cover. So this is a major issue because breast cancer, roughly 13 to 15% of the patients are hormone receptor positive, and these patients need a immunotherapy or a targeted therapy, which is not covered by our insurance company. Treatment is not financing by any institute. Number of time patients are basically self-paying, or they are basically getting the treatment by some support like the panels or other things. Otherwise, it's difficult to treat breast cancer patient, those who are basically hormone receptor positive for 1 year. Building treatment infrastructures, outreach center in tier 2 cities and district hospital. I want to convey you that the medical health services, we have always seen these metro cities like Delhi because we are practicing here, but we never goes and see the district level hospital facilities or infrastructure in our clinical practice. So in last but not least, on the basis of the population-based registry data and the journals published the Indian data, I can just say very clearly, projection of cancer incidence shows an urgent need, and that's why I'm discussing this topic today in this IMA meeting for urgent strengthening and augmenting existing diagnostic and treatment facilities, not even in the metro cities or a tier 1 city, must be in the district hospital, B-class cities, or a primary healthcare to detect the breast cancer in early stage. And we can see that we detect the cancer in early stage, and we are talking about the curative intent treatment with comprehensive multimodality treatment like surgery, radiation, and medical oncology side, which is inadequate and unable to handle the current load of cancer in India because we are not having any infrastructure at a B-class city. Can we change this picture and say that we can detect the breast cancer in early stage? I am just comparing the United States. They detect the breast cancer from 0 stage to 1 stage in 16% of the patient, where India diagnosed roughly 45% patients only in stage 3 is locally advanced. Can we change this picture? I have shown the data because I want that my colleagues, my medical fraternity doctors, those who are practicing, must know about the magnitude and gravity of this disease, that how much this projection will change the picture in future if you have not alert now. Thank you very much for your kind attention, please. If any question, I will be very happy to reply.
Well, a very thank you to Dr. Sunil Gupta, sir. Yeah, am I audible? Yeah. So many thanks to Dr. Sunil Gupta, sir, for this lovely talk on epidemiological patterns of breast cancer in India and the challenges that we are facing. Do we have any questions? I cannot see in the chat box. I don't think so. Any questions are there?
If no
but,
questions,
I would like to just put certain points, and Dr. Sunil Gupta has already put it actually, and I also translate with the same feelings that with the current pandemic going on, we are seeing that a lot of non-communicable diseases have taken a backseat. And it was in the month of April, May, June, when we realized that, okay, probably COVID would go down, it would go on the downslide, then probably one can start, treating them. But it is, what we are seeing is it's not happening like that. So it is now time to address these non-communicable disease with a very evidence-based practice, and make sure that these are not being postponed for a later date. Breast cancer is one of them. And Dr. Sunil Gupta has rightly projected that in India, we are losing almost 1 in 2 ladies who are being diagnosed with breast cancer, almost 50%. And he rightly mentioned that the last year, 2018, the figure was nearly 90,000 of mortality. Today, till date, COVID has nearly taken a toll of 1.2 lakh. Almost a year is going to happen. Breast cancer is almost killing the similar numbers every year. So we have to just pick up our cudgels against this disease and make sure that we detect it early. If not, we are unable to change the incidence, but at least early detection, early screening. And it is possible by raising this awareness. And thanks to IMA, the administrative body that they have chosen this idea of bringing out such programs. And I'm sure this would help. Thank you, Dr. Mukesh Verma. Yeah.
There are questions by some delegates. Dr. Munish Sen is asking, what are the chances of a lady developing CA breast if the mother has got it? And Dr. Jalpota is asked, the question is, what is the treatment cost of stage 3 breast cancer?
Mukesh, yes, Dr. Mukesh, if
sir.
you see hereditary cancer, roughly 10% of the women can develop the disease as a hereditary cancer. 90% of the breast cancer patients are sporadic in nature. So once there is a family history, we always do the BRCA1, BRCA2 to see whether there is a chance of hereditary cancer in breast. Sometimes there is a breast, ovarian, and colon syndromes. but routinely 10% patient can have a family history to develop the breast cancer. And regarding the stage 3, Dr. Mukesh, this is a locally advanced disease as per the UICG, clinically stage 3B. We should go for a neoadjuvant chemotherapy as per the receptor report, whether it's a hormone positive or hormone receptor positive versus triple negative versus hormone positive versus hormone negative. We should see all the receptors, and depend upon that, we should go for a neoadjuvant chemotherapy first, followed by clinical assessment. And if patient is operable, then surgery, followed by pathological report, again adjuvant treatment if required, or radiation as a treatment of choice. Talk about a treatment cost totally depend upon the receptor. If only chemotherapy, radiotherapy and surgery, the cost would be around, surgery would be roughly 1.5, radiation is roughly 2 lakhs, and routine chemotherapy 1.5. But once we are talking about a immunotherapy, this will take a 1-year course, and the cost will be at each cycle roughly 60 to 70,000 more. So almost a immunotherapy plus chemotherapy cost would be roughly 3.5 to 4 lakh rupees. and the surgery plus radiotherapy is 1.5 to 2 lakhs. Means almost roughly 7 to 8 lakh rupees if HER2 receptor positive, or go up to 10 lakhs, because if the body weight is high, then you calculate the dose as the body surface area and body surface per kg body weight.
Thank you. Thank you, Dr. Sunil Gupta, sir. And our chairperson, Dr. Piyush Bajpayee. I just came to know that Dr. Neeru could not join. But thanks to her also.
There is one more question.
Ma'am, there is one question.
Is there any question?
Yeah, ma'am.
Yeah, Dr. Rakshit Garg is asking, should all patients of carcinoma breast be screened for ovarian cancer?
Routinely we are not doing. Routinely we are not doing until unless there is a family history or a BRCA1, BRCA2 positive. Routinely we are not doing.
Excellent. Thanks, sir.
Thank you, sir. Thank you. Thank you so much, Dr. Sunil.
Thank you to all of you.
So, thank you. We are through with the scientific session. I hope you all enjoyed this initiative, and soon again we will be back again with the set of ECMEs. Before handing over mic for vote of thanks, just want to conclude that all of you should take good care of yourself in Corona Kal. Be connected with each other, and special care to be taken of our senior doctors. थोड़ा समय निकालिए, उनको कॉल कीजिए और उनका हालचाल पूछिए. Thank you. I just hand over to Dr. Selangia for vote of thanks. Dr. Selangia, sir.
Dr. Selangia is probably not joined, or probably he's not on the panel, I suppose, panelist. He has joined through other link, if he has at all joined.
So I request Dr. Mukesh to conclude with vote of thanks.
I would like to thank all the esteemed speakers, Dr. Sunil, Dr. Arun, and all the esteemed speakers, the chairpersons, and particularly thanks to Venkateshwar Hospital. Venkateshwar Hospital has always been associated with our academic series. They have always supported our academic endeavors. And this is my pleasure to thank the Venkateshwar team. I would also formally thank all the chairpersons and the delegates. Despite being a leisure Sunday evening, everybody is here, and they are all attending the scientific session. I once again thank you all and wish these academic series to continue in future. Thank you so much. Dr. Deepmala.
Thank you.
Thank you all.
Thank you.
Special thanks to our moderator, the great moderation done by Dr. Deepmala Lalchandani ma'am. Thank you very much for conducting the CME very well mannered, and thank you, ma'am. Thank you.
It was an
Thank you, ma'am.
experience,
Thank
new
you.
experience for us. The next
Thanks.
time we'll do much better in this.
Definitely, ma'am.
But
Thank
we'll
you.
continue
Thank
with
you.
this.
Thank you, ma'am. Thank you.
Thank you,
Thank you,
Dr.
everyone.
Mukesh.
Thank you. Thank you.
Good show,
Thank
team.
you,
Team IMA.
Venkateshwar.
Good show, team IMA Dwarka. Congratulations. Nice beginning.
Yes,
Thank you,
sir.
sir. Thank you. Thank you
Thank you,
very
sir.
much, sir.
Thank you. Leave behind. Fine.